Invite Dr. D. Ramamurthy himself to talk about very important aspect of all types of cataract surgery. It is much more important for our premium IOLs, and he'll tell us how to go about in these cases. Dr. D. Ramamurthy, please.
Thank you, Dr. Tityal. I think biometry for premium cataract surgery is perhaps of paramount importance, as already emphasized. Irrespective of the type of surgery that you do, the kind of intraocular lens that you implant, if you are not able to achieve metropia or the target that you were aiming at, obviously that would lead to a dissatisfied patient. As far as biometry is concerned, there are two aspects to it. One is accurate measurements using the right kind of equipments, and then calculation using the right formula. In the next few minutes, I'll be dwelling upon both these aspects. There are certain simple aspects that you need to remember very clearly. That is, for every millimeter of error in the axial length calculation, it is said that 3 diopters of error would be the intraocular lens power calculation error. But that is for average eyes. But when you come to extremely long eyes, say in the sake of 30 millimeters or so, the error induced is much less. But more importantly, in short eyes, say 20, 18, 19 millimeters eyes, it's almost 3.75 diopters per millimeter of error, because it's after all a percentage of the error that you get in as far as axial length calculation is concerned. The most important factor is that nowadays with the optical biometers, excellent understanding of immersion biometry, axial length calculation quite often is quite accurate. More often errors are induced by errors in keratometry, and what you need to understand is every 1 diopter error in the average calculation of the keratometry will lead to a 1 diopter error in the IOL power calculation. And when you are doing it, very often axial length calculation takes up a lot of our effort and time. But the keratometry is given a little go by. And in case there are errors coming into that can again compromise the results quite significantly. One extremely important point I want to drive home is that you may not be able to afford optical biometry, it may not be available in your center, but then please do not do applanation A scan. I think it's time you gave that up, because it comes in direct contact with the corneal surface, indents the cornea. It can induce a significant amount of error as far as axial length calculation is concerned. Immersion A scan done by an experienced optometrist or by surgeon also gives excellent results. The only advantage of optical biometry, as I say, is idiot proof, in the sense that even if the person doing it is not so experienced, not so conversant with the procedure, he or she may end up getting reasonably good results. The immersion A scan done in experienced hands, especially in the normal run-of-the-mill eyes, can give you excellent results. I often tell my junior colleagues that in case you have to choose between investing in an optical biometer or upgrading from a simple phacoemulsification system to a more advanced phacoemulsification system, opt for an optical biometer, because you can very well do most of your cataract surgeries even with a straightforward instrument, but an optical biometry is extremely important to give you the kind of results that a premium intraocular lens, or for that matter any cataract surgery patient, comes to expect today. There are multiple options that are available to you, and we have almost experience with all these options in different centers. And let me assure you, once you understand these machines and use them optimally, all of them work quite well. So depending upon your comfort level, depending upon your relationship with a particular company, you can opt for any one of them. Just because you have an optical biometer, this does not assure you absolutely normal results. For example, this is an IOL Master 700 instrument being used, and you can see the macular pit, the foveal pit over there. It's a good reading that we get. So 2 consecutive readings, what we get is just about a difference of about 10 microns in the axial length and a 0.02 diopter difference in keratometry. That obviously translates to an excellent calculation as far as the intraocular lens power is concerned. That is 15.75 or a 15 diopter lens being suggested in both the eyes. There's exactly the same patient, errors in biometry, the same excellent equipment is being used, but poor fixation of the patient, no foveal pit is visible. Only a well-trained observer can make this out, and in case that has been missed out, then you can this can result in a 190 micron difference in the axial length, and as far as keratometry is concerned, there can be a 0.5 difference in keratometry. So what does this translate to? Almost a 1 diopter difference in the calculated intraocular lens power. So it's not just enough to have the right kind of equipment, it's also important that you understand the nuances of its usage, the abilities, what exactly are the green signs that you look for, and use it optimally to get repeatable outcomes. This is a checklist for axial length that I've been using for almost 20 years now, much before optical biometers came into being, but still it's extremely relevant. Even if the cataract is meant for only one eye, always measure for both eyes in every patient. And in case there is a difference in the measurement in the axial length of more than 0.3 millimeters, then which would result in a difference of about 1 diopter, unless there is already a proven evidence of anisometropy between the two eyes, go ahead and repeat the calculation. If the axial length is less than 22 or more than 25 millimeters in either eye, go ahead and repeat the calculation. And if the axial length measurement does not correlate with refraction, this sometimes might happen because the lenticular myopia is set in, but still it's always good to verify. And in case you are not able to get correctly positioned high, steeply raised echoes in an immersion A scan, it's a good idea to repeat your A scan. And if in case the patient has problems in fixation, nystagmus, poor cooperation because of age, etc., is always get multiple readings or even by multiple observers is a good idea. As far as the choice of formula is concerned, I am going to just concentrate on one specific formula. Multiple different formula is available, but obviously I do not want to confuse you with all the options that are available. For the last about half a decade, we have been sticking on to the Barrett suite of formula. It is not just a single formula, but a combination of formula. The Barrett Universal 2, which is the core of all formula, which takes into consideration the thickness of the intraocular lens that you are implanting, and no adjustments as far as extremes of refractive error is needed when you are using this formula. The Barrett toric calculator is our go-to formula for all our intraocular lens power calculations, which gives us straight away an idea as to whether the patient needs a toric intraocular lens or not. In case the patient requires cataract surgery, post laser vision correction, or even radial keratotomy, the Barrett 2K formula is the go-to formula. If you are contemplating a toric intraocular lens in a post-refractive surgery, Barrett 2K toric calculator, and in case you have a refractive surprise, the Barrett RX formula. The basic idea is that I am not no financial interest in this, but simply what we have found is that when we stick to this simple dictum that stick to one formula, irrespective of the kind of cases, we have found that most often, it's not that 100% accuracy, most often we end up with excellent results. And just in case you do not have access to an optical biometer, most of the optical biometers that I showed you have the 2K formula, the Barrett toric calculator, as well as the Barrett Universal 2 incorporated in them. But even in case you do not have them, even in centers where we do not have an optical biometer, we do an immersion A scan, we do a keratometry, and go ahead and use the ASCRS and APASCRS websites, where right in the opening page, in the home page, you have this icon for the IOL formula, and you can get the benefits of all these formula right here. So just because you do not have an optical biometer, that does not mean that you cannot enjoy the advantages of using this extremely modern, well-defined, well-established formulae. As far as astigmatism is concerned, I already mentioned this in an earlier talk of mine. That is extremely important, especially when you talk about multifocal lenses, that unless you correct the astigmatism adequately, it's not going to be a happy patient. And posterior corneal astigmatism, surgically induced astigmatism, toricity ratio are things that we need to understand quite completely. And today, when we go to, when we take the first optical biometry, even once the patient has a cataract, and even if before the patient is taken up for counseling for the cataract surgery, the first biometry that we do is under Barrett toric calculator, simply because this tells us immediately whether the patient requires a toric monofocal, toric multifocal, or a non-toric lens. The reason we have shifted to this and not to Barrett Universal 2 is, earlier we used to do Barrett Universal 2 that used to, the patient just had a 0.75 diopters of astigmatism. You used to talk all about monofocals, multifocals, but when we take the patient on for total calculation, we find that the patient actually requires a toric intraocular lens, and the total conversation changes. So the go-to formula is Barrett toric calculator, and then subsequently we decide based upon whether it's a monofocal and multifocal and go ahead with that. And as I already mentioned, especially if you are going ahead with multifocal intraocular lenses, it's extremely important that you treat even extremely low levels of astigmatism. This is a patient who had just about 0.87 diopters of against the rule astigmatism. We implanted a Panoptix intraocular lens in him, and he ended up with an extremely good near vision. But as far as distance vision is concerned, it was just about 612 parts, required a significant correction, and a very dissatisfied patient. The same patient, when we put him on Barrett toric calculator, it showed us immediately that the patient required actually a T3 toric multifocal lens, and that's exactly what he received, so that he ended up with a 6.6 distance vision and N6 for near and intermediate as well. Actually, we ended up doing a laser vision correction in the second eye subsequently. So in summary, I think whether you do optical biometry would be the way to go, but just in case you do not have access to it, go ahead and use immersion A scan. And in case, even if you use the immersion A scan, do have access and understand the latest generation IOL power formula. And I do strongly believe, whether it's premium intraocular lenses or simple cataract surgery, emmetropia for all is a real possibility. And as cataract surgeons of the third millennium, you owe it to your patients and yourself to achieve it. Thank you so much for your kind attention.
Thank you very much, Dr. Ramamurthy, for highlighting, I think, one of the most important aspects of perfecting the refractive cataract surgery. And unless you have a good biometry, you cannot achieve this outcome in our patients. And he talked about various aspects of getting good corneal profile, good axial length, and most importantly, selecting the good IOL power calculation formula, and knowing that what patient would require subsequently in these cases. Thank you, Dr.